Hello, my name is Amanda Nopakun. I am from the Family Medicine Residency Program at Madigan Army Medical Center, and I have no known reportable disclosure. I am eager to share with you an interesting twist on a common case presentation called A Case of an Inappropriate Salt Result. A 56-year-old female with hypertension, hyperlipidemia, and diabetes presented to the emergency department for nausea and dry heaving. At time of evaluation, her serum sodium was 133 prior to fluids, and she had a normal BUN to creatinine ratio and a normal serum osmolarity. Her symptoms improved with ondansetron and IV fluids. She was then discharged home. She returned again 4 days later for an episode of dizziness that led to a fall with a mild head injury. Per the patient, her blood pressure and blood glucose were normal at the event, and she had appropriate fluid intake. But she did report this insidious progression of dizziness that started with the addition of a hydrochlorothiazide to her antihypertensive regimen 2 months prior. She had a normal EKG, chest X-ray, and head CT. Labs at admission were notable for a serum sodium of 128 and a serum osmolarity of 269. With these results, our patient met criteria for a hypotonic hyponatremia with a diuretic or medication effect most likely contributing given her history. The next step in her evaluation was for hypovolemic versus a euvolemic presentation. Her physical exam and labs were consistent with euvolemia. Thus, she met criteria for hypotonic euvolemic hyponatremia, which is the right-hand column on this slide. Her TSH and ADH were normal, and her hemoglobin A1C demonstrated good glucose control at 6.0. The American Family Physician published a review of hypo and hypernatremia with an algorithm for approaching hyponatremia. Following this algorithm, our patient progresses down the low osmolarity pathway to a volume state evaluation. From there, we go on to determine what her urinary studies were. Her urine sodium was 31 to 35 milliequivalents per liter, and her urine osmolarity was 137 milliequivalents per liter. By labs and exam, our patient presented with hypotonic euvolemic hyponatremia, and this presentation was most similar to SI-ADH if you follow the blue boxes on the algorithm. What's interesting to note is most diuretics present in the red box with a hypovolemic presentation. Hypertension affects 30% of the world's population, and thiazides are first-line medication for this. They work directly by sodium reabsorption and excretion. On review of our patient's presentation by the hyponatremia algorithm, she would fall into the evaluation for SI-ADH and benefit from fluid restriction. But an observational study by Burst and colleagues demonstrated that strategies to elevate serum sodium above and beyond thiazide sensation has been found to either have no therapeutic benefit or increased probability of overly correcting serum sodium and patient harm. This led to our clinical question: should family medicine physicians be monitoring patients on thiazide diuretics for hyponatremia? There were a lot of conclusions and learning points from this patient presentation. First off, thiazide-induced hyponatremia does not follow a standard euvolemic or hypovolemic algorithm. Instead, it can present like SI-ADH, like as in our patient. There is a range between 4 and 30% of patients that are on thiazide diuretics that might have an associated hyponatremia. A systematic review of these patients starting thiazides found that the clinical presentation for hyponatremia happened on a mean of 19 days, but there was a range of between 8 and 30 days. As was discussed earlier, for a patient, it is not recommended to augment sodium normalization except for cessation of medication because of risk of patient harm. An observational study was done in the last year by the Hyponatremia Registry, which reviewed 477 patients from 225 sites in the US and the European Union. The patients were presenting with euvolemic hyponatremia and with the most likely trigger the thiazide that they were on. It was noted that the thiazide medication was only withdrawn 57% of the time. And on a population review, they found that 18% of the hyponatremic patients did not receive any treatment and were often discharged with unresolved hyponatremia. There was a study by Friedman and colleagues that did a thiazide reach challenge in patients who had previously developed thiazide-induced hyponatremia. They demonstrated a repeat marked reduction in their serum sodium and increase in urinary sodium excretion, even with a single dose re-challenge. Thus finding that once a patient has developed this hyponatremia with thiazide diuretics, they are more likely to have recurrence once it's restarted. And to prevent patient harm, it may be beneficial to place a thiazide as a medication allergy. Thank you for your time. These are my references on the next 2 slides.